But because of the power of genetics, I see this as power, that we can do something, we can intervene at a time and not wait for nature to take its course. So the genetic testing is crucial, and we're learning more about not only to make a diagnosis and predict the future, we can also then personalize the medical approach we take, or we can take those understanding the gene defect and create new therapies such as gene therapy that can modify the patient's own stem cells and hopefully correct the underlying disease. But if you go back to 1996, when you had only a 16% chance of cure, the only thing I could promise a parent was that I'll learn something from it. Most of my patients were very young. You were 5, Jack was 3. And a funny story about Jack is when he came to the University of Minnesota, he was coming there because of his underlying congenital heart disease, and the cardiac surgeons were doing his surgical repairs. But he was not diagnosed with Fanconi anemia, and yet we had the largest Fanconi anemia clinic in the world, and yet no one thought about it because he came to us with another diagnosis. It's another lesson we've learned is that once you're labeled with a diagnosis, even if it's the incorrect one, oftentimes it's hard to get rid of, and you fail to make the correct diagnosis. But it was actually a medical student at the University of Minnesota, not the cardiothoracic surgeon, not the GI doctors who take care of my patients with FA. It was actually a medical student who had rotated with me for a period of time and said, "Did you consider Fanconi anemia?" And Jack, and that's how he was diagnosed, and then came back very early on for his transplant. But when you came in 1996, the results were poor, but we learned from kids like you. The problem is that it's an underlying part of Fanconi anemia is a DNA repair defect. These patients can't take chemotherapy prior to their bone marrow transplant, and so oftentimes their graft would be rejected. The donor's stem cells would be rejected because they couldn't give sufficient amount of chemotherapy because of the fact that her body could not tolerate it. But eventually we figured out how to do it, and when Jack came along in early 2000s, we had learned how to do at least what kind of chemotherapy to give, and his chance had skyrocketed to 35%. Now, as a parent, you're kind of hoping for more, but going from 16 to 35, it all depends on where your perspective is. And so that was a major advance. We continued to make advances over the next couple of years, and today, it's greater than 90% chance of being cured of your bone marrow failure or leukemia. But we got there because of the patients like Allie and like some of you in this room that allowed us to learn something about what the current therapy is, and then to look at and see what didn't work well, what could be made better, and we're continuing on and on to make great strides. And so now what we hope to do in the not too distant future is to actually use genetically modified bone marrow stem cells to treat patients with Fanconi anemia. And the early results that are coming out from Spain right now look very encouraging. So it's an evolution. So there's a couple lessons in all this. When I was working with stem cells and looking at ways of trying to find better donors for our patients, some of you may have heard about the story of the Molly Nash case. This was a case which later became a movie, My Sister's Keeper, which was about a mother who was desperately looking for a donor for her child, knowing that if she had a sibling donor, her child would have a 70% chance of survival. If she had an unrelated donor, it would be less than 20.